Hello, my name is Elisa Othello Sidney. I'm a respiratory therapist. In the following section, we're going to talk about bag valve mask and bag mask ventilation. And by the end of this discussion, you will understand the indications of bag mask ventilation, the goals, as well as the differentiations between pediatric and adult population. So when talking about the goals, when we are ventilating a patient, we're trying to reduce their respiratory effort if they are still breathing, optimize oxygenation to the heart and the tissues and throughout the body, and correct any imbalance in gas exchange that we might have, any hypoxemia or hypercarbia. And the indications are if you have a patient who is agitated after multiple interventions, this could be a sign that your patient is decompensating. The opposite as well is true. If you have a patient who's becoming more and more lethargic or somnolent, that can also be an indication that they're decompensating, and you might want to start thinking about the next steps that you would need to take. Any low pressure alarm or alarms on the ventilator where you're not sure what the issue is, it's always safer to remove the patient and bag them. That way you ensure that they are getting proper ventilation. When transferring a patient either from room to room or from one section to another, we can do it on the bag mask ventilation as opposed to taking an entire ventilator. If ever a patient has a leaking cuff in a trach or a endotracheal tube, then when you put them on the bag mask, you can ensure the amount of ventilation they're getting as opposed to with a ventilator that would probably have a lot of leaks. And any sign of hypoxia, any sign that your patient is just not doing well, it's always better to just bag them. All right. So when talking about ambu bags, they're capable of delivering 100% oxygen if they're hooked up to a O2 tank with a proper mask seal. When somebody has an invasive airway like a trach or an endotracheal tube, then you don't have to worry about the seal. And if it's not attached to any oxygen, then the bag will deliver 21%, which compared to 16% with mouth to mouth is still better. You can even add a mixture of helium and oxygen to an ambu bag if ever you need to ventilate someone with an upper airway obstruction. You can do that with a mask, and even a lower airway obstruction via the mask or an invasive airway. Every ambu bag can hold 1.5 to 2 liters of volume, and the reservoir bag that is attached at the back holds an additional 2 liters of oxygen. So whenever your bag is properly inflated, you generally know that you're getting a high amount of FiO2 with most respiratory patterns. So when talking about the different components of the ambu bag, there is a non-rebreather valve that is located on the bag. And this is essential to the proper and safe functioning of every ambu bag. It has to have one. And what this valve does is whenever a breath is given and the bag is squeezed, that valve opens, allowing gas to be forced into the patient's lungs. And at the end of inspiration, when you stop, the valve closes and redirects the expired air from the patient to the ambient air so that there's no CO2 rebreathing. On every bag as well, there is a pressure relief valve or a pop-off valve, which is located here on the ambu bag. And what that does is you set the amount of maximum pressure that you want to set, and it is a breath-by-breath measurement of the amount of pressure that's being delivered. And if you exceed the amount of pressure that you set, that pop-off valve will pop off and it will vent out the excess volume. So it helps to prevent barotrauma in the lungs and just any damage that you might do just from overinflating the patient's lungs. With every or almost every pop-off valve, there is a bypass clip, and basically, if you close that clip, it stops the valve from popping off with an excess amount of pressure. This is only used in cases where you need to ventilate patients with high amounts of pressure. And just make sure that when you do put it on, that you check to make sure that it's on. And by doing that, you would just block the entrance of the ambu bag and squeeze and make sure that the valve doesn't pop off. And with every bag, there is also there's also the option, or well, not every bag, but most bags have the option to add a PEEP valve, which is an external valve to add additional PEEP. Usually, if you have a ventilated patient with a set PEEP, you want to have a PEEP valve with your Ambu bag. So this is what the PEEP valve looks like, and it attaches to your Ambu bag. Not every Ambu bag has the attachment for it, so if you have a ventilated patient, you want to get the Ambu bag that has the additional attachment for the PEEP valve. And it just connects like this, and then you can choose the setting with this red cap. With Ambu bags, there are multiple types. There is also a flow-inflating bag. So those are usually mainly used with infants, and in the OR, you'll almost never see them with adults. And what a flow-inflating bag is, it is connected to compressed air, and it uses that air to inflate the bag. So it has to be hooked up to a gas source, usually oxygen, and without it, you can't use the bag. So with this, you have to ensure that you have a very, very good seal or your bag won't inflate. And all of them come with a pressure manometer on it so that you can see also breath to breath how much pressure you're getting, because the risk of barotrauma are higher with infants than with adults. So the steps for ventilation. So before using any Ambu bag, the first thing you should do is check that it is functioning properly. So when we're talking about the functioning of an Ambu bag, we want to make sure that the whole bag is intact, that there are no tears or holes in the actual bag, that everything is functioning properly. We turn on the oxygen and make sure that our reservoir bag is able to inflate and hold the gas in the bag. It's not leaking anywhere. Again, that you have your PEEP valve if necessary, and a mask. When checking for leaks, it's similar to when checking the pop-up valve. You take your Ambu bag, you block here, and then you squeeze and make sure that it holds the pressure. If there's any leaks, replace the bag with a new one. And then along with that, you also want to make sure that it's always attached to oxygen, an oxygen source. If it's a flow meter, make sure it's on the flow meter. If you have an oxygen tank, make sure it's attached and the tank is open but not running. So when we're actually talking about ventilating with an Ambu bag, we have to take into different considerations the positioning of the patient when talking about adult versus pediatric. So right now we're going to focus on adults. So when talking about the placement of an adult or just bagging an adult, you start by, washing your hands, putting on your protective equipment, depending on the patient's isolation status, your gloves, your gowns, all of that. You have to remember that when bagging a patient, it is an aerosol generating procedure, so there is risk of contamination if your patient has an infection. After you've checked that the Ambu bag is functioning properly and that it is attached to your oxygen and on, now as you're preparing to use it, you explain what you're going to do to the patient, even if they're not conscious. And then you make sure your patient is on their monitors, and you disconnect the patient. If they are on a ventilator, you would disconnect the patient from the ventilator. If not, you would attach your mask and prepare to ventilate. When we're talking about the positioning of the patient, we want to do a head tilt jaw thrust. So you want to tilt the head back and then use your fingers to thrust the jaw forward or lift the chin. And then you would place your mask. So when holding the mask, you're going to use an EC one-handed technique. So you make your the shape of a C with your fingers. You place it over the top of the mask like this, like a semicircle, and then you would take these 3 fingers and place it under the mandible of the patient and then lift as you provide your ventilations. Whenever doing this in any technique, you have to just make sure, because there is soft tissue here, we're placing the mask in the areas of the eyes and the nose, that you're not putting an excess amount of pressure on the face and around this neck area, just enough to have a proper seal and ventilate your patient. And if you have two people, then you'll do the two-handed ventilation technique, which is similar, same thing, two C's over the top. So like two semicircles to make the full circle, and then the three fingers under the mandible lifting as someone else who's with you ventilates the patient. This is the way to get the best seal, and if you have an extra person, it's always preferable to do two-handed bag. With every, when we're ventilating patients, for an average adult, we're thinking of 6 to 7 milliliters per kilo, which most of us can't calculate in our head. It's about squeezing 1/3 of the bag. And when you squeeze, it's for around 1 second. And you want to make sure that your reservoir bag, if it's attached to oxygen, doesn't refill in 2 seconds or less. Then your flow is too high and you can't actually see the respirations of the patient in the bag. And you want to really make sure that when ventilating a patient, that you don't give too much volume or excess amount of pressure. You can create gastric distension when you do that. And if the patient's not NPO, then you can cause aspiration. So selecting the size of a mask is essential to proper ventilation through bag mask ventilation. If your mask is too big, you'll have leaks. If it's too small, you won't be covering the areas that you want. So when selecting the size of the mask, what you want to ensure is that the mask is covering from the top of the nose to the base of the chin, and it is covering both the nose and the mouth from here to here above, and that this base part is not over or passing the level of the chin, because if it is, then it's too big and you'll have a lot of leaks. Some things too to consider when ventilating a patient: if somebody has facial hair or beard, it might be a little more difficult to have a seal, as well as if somebody doesn't have any teeth, then you might consider using an additional airway like an oral airway if they are unconscious, which could help ventilate the patient. Or if your patient is semi-conscious or fully conscious, then we would go more for a nasal airway to make sure that the air is getting into the airway. However, one thing to consider when using a nasal airway is if you have someone who has major trauma to the face area, then we want to avoid that because it can be placed intracranially. So when using it, as previously said, you would check your bag, you would connect it to oxygen, and it says 12 to 15 liters. Usually we flush the flow meter just to make sure we have enough going. And like I said, with a proper seal, this should deliver close to 100% oxygen. With an invasive airway, you should be getting that 100% from your bag. If the patient is on a ventilator, either with a tracheostomy or an endotracheal tube, you will remove them from the ventilator and then put them on the bag instead, and then just attach it directly to their invasive airway, and then you would bag that way. If your patient is spontaneously breathing but just needs the additional support, then what you try to do is follow their breathing pattern if possible. So you just look for their chest rise and try to give them a breath as they go to take a breath to make it the most comfortable for them. Now, if we're talking about ventilating someone who has recently had an accidental decannulation with their tracheostomy and they are able to move air through their upper airway, then what you would do is take either a sterile gauze or something to block the stoma, and then you would just ventilate the patient through the mouth with a mask like any other regular patient. And if they do not have a functioning upper airway, in cases like with a laryngectomy, and then you need to ventilate, what you would do is you'd have to take a smaller mask to create a seal around the area of the stoma and then ventilate through there. So as previously said, when we're squeezing the bag, we're squeezing for about 1 second, about 1/3 of the bag. And what we want to see when we do that to know that we're getting proper ventilation is we want to see the chest rise as we're ventilating the patient. We want to see that their oxygenation is improving, that if they had any mismatch with their gases, that's improving. We want to see that their color is improving. And on auscultation, we want to hear good air entry. And when you're bagging on exhalation, you'll see that condensation from the mask if your air is going in and coming out properly. So after ventilating a patient on the bag, for whatever reason, if it's a ventilated patient, then you'll remove the ambu bag, and then you'll put the patient back on their ventilator, make sure that it's started, that they're comfortable, and that you have your alarms back on, and that your monitors are on and your patient is comfortable. And then you'll still want to have somebody come and assess them after the situation. So now when talking about kids or pediatric population, a lot of times children have a bigger skull in the back of the head, so their head or their body doesn't fall in the same way as an adult would when you lay them on their back, and their head is not in the proper position. So in order to get a baby or a kid into the proper position to ventilate them, you never want to actually extend their neck. What you'll do is you will place either a towel or a cushion underneath their shoulders so that their head falls back naturally into the proper sniffing position to ventilate. And then you would do basically the same thing, and then taking into consideration that the smaller the kid, the smaller their lungs, and the less volume you need to ventilate them. And then with kids, they also breathe at a faster rate. So for adults, we're targeting generally 10 to 12 breaths per minute if they have proper cardiac function and at least a systolic above 75. With kids, they breathe a lot faster. So with them, we're going more for higher breaths. With newborns, 60 to 80 breaths a minute. With infants, 40 to 60. And for kids, 16 to 20. So the higher end of adults.